on the 10th of October. This session is going to dwell on non-invasive, minimal invasive open surgery and their complications. We have a group of seasoned urologists to handle this session. So I will ask you to pay rapt attention as we go ahead. Without much ado, I'll call on Dr. Magnus to start on extracorporeal shock with lithotripsy. Dr. Magnus, you have 15 minutes. Is he enabled to share his screen?
Yes, go ahead and share your screen, Dr. Magnus. Dr. Magnus, can you hear me? Dr. Magnus, can you hear me? Are you using an external audio device?
I can't even see him on the screen.
Is there? Okay, no, I'm confessing with okay. Let me see whether he has logged out. If he has logged out, let me check. Okay, it's not there, so let the next person carry on.
Okay, let's not waste time. I invite Dr. Baba Gana, who will be speaking on pilotomy and nephrolithotomy for kidney stones. Dr. Baba, you have the floor.
Good evening, Mr. President, the House Executive, senior colleagues and colleagues. I am to present open pyelolithotomy and nephrolithotomy. I'm sharing my screen. Is it visible, sir?
Yes, it is.
Yes, go ahead. Put it on slideshow.
Yes, thank you, sir. This supposed to be the last option when we come to treatment of renal stone, but I will be the one to start this session of treatment option available for renal stones. Briefly, this is the objective of this presentation. Brief introduction, current global trend, and then the guidelines available. And then we briefly look at how open nephro and pyelolithotomies are done. And then we conclude. Nephro and pyelolithotomy both means the opening for surgical opening of the kidney to remove the stone. So it's a surgical removal of this renal stone from the kidney. Nephro, when it's through the renal parenchyma, and pyelo is through the renal pelvis. This procedure has been in existence since time immemorial. The first removal of stone from kidney was done by Cardan of Milan in 1550, where he removed about 18 calculi in a patient with lumbar abscesses. Then Harry Morris did the first nephrolithotomy in an otherwise normal patient, and Lower in England in 1913 revived the interest of pyelolithotomy because after Milan, many surgeons don't see the reason for removing stone via opening. Then transnursal extended pyelolithotomy was popularized by Gilvanet in 1965. To interest you, even in the Hippocratic Oath, there is mention of stone surgery. And then it was mentioned that I will not use the knife, not even on sufferer from stone, but will withdraw in favor of such men as are engaged in this work. This underscores the need to refer patient if you cannot handle. And in this our era, unless it become the only option, often surgery should not be done to patient. Rather, patient should be referred to where he can get the other option available if he can afford. What is the current global trend about open renal surgery? Generally, the trend is that many centers have either stopped or has virtually reduced the percentage of open surgery for renal stone. In Turkey, a report by Azza Oral have only 1.1% of the renal stone surgeries that were opened. And in USA, in almost 10 years, the number of open surgery done there was 334, with just 35 stones open renal surgeries per year. This brings down the percentage of open renal surgery to less than 1%. Here in Africa, in Egypt, Abdus Lazim did and found out that in Masura, found that from 1980 to 2009, the rate of open surgery has reduced drastically from 78.1% to as low as 4.4%. And they concluded that although open surgical intervention in managing renal stone had declined significantly over the last 3 decades, it is still represent a salvage procedure in a reasonable number of patients. And they also concluded that strategies should be made to keep this surgical skill in basic urologic training. In another hospital in Egypt, in Alexandria, over 6 years, they did over 5,000 surgery for renal stone, out of which 533 were opened, making the percentage to be 10.3 only % that were opened. And also they concluded that some renal stones still require open surgery. Here in Nigeria, in Lagos, in 2019, a 5-year review was done, and the percentage of open surgery was as high as 53.9. And in Sokoto, Mungari et al. In 2006 also had percentage of 74.0% of open surgery. And we did our series in 2 years. We have 21 patients that had open surgery out of 84 patients diagnosed to have renal surgery. So this tells us that even though globally, many centers have stopped opening for stone, but here in Nigeria, the rate is still as high as 50% and above. So what are the current guidelines regarding the place of open surgery? In the AUA guideline, it has been clearly stated that open surgery should not be offered at first line therapy to most patients, though there are a few exceptions, like rare case of anatomic abnormalities, large or complex stones, and concomitant reconstruction. The EAU guideline also recommended that laparoscopic or open surgical stone removal should be offered in rare cases in which shockwave lithotripsy, retrograde or antegrade ureteroscopy, and percutaneous nephrolethotomy fail or are unlikely to be successful. So as such, open surgery should be considered as the last treatment option after all other possibilities have been employed. Surprisingly, in the 12th edition of Campbell, which one of the books we usually look into, there wasn't any mention of open surgery. this emphasize, and I think it's deliberate, that now open surgery is the last thing surgeons should think about in patient with a stone in the renal stone. Then why are we discussing open nephrolithotomy or open pyelolithotomy in the 21st century? Actually, in Nigeria, here more than half of the renal stone were removed via open surgery. So it still serves as a salvage procedure in some patients, even in developed countries. And due to financial constraint, more than 70% of patients cannot afford the alternatives to open surgery, which is PCNL and the other options available. In fact, the purchasing power of an ordinary Nigerian may need to save for more than 5 years to get money that will be enough for him to do PCNL. And even the facility for PCNL and other options are not readily available in most centers. And also facility and skills are limited for other options such as laparoscopic or robotic renal stone surgery. As such, we should still be discussing nephro and pyelolithotomy in Nigeria.
Well, he has network issue. Okay.
Can I continue? It's like the network just gets interrupted just now.
Go ahead.
But I think I'm back. Thank you very much, sir.
So you have to share your slide again. We are not seeing your slide.
Oh, okay, sorry. Just a minute, sorry. I don't know if I have left some slide before. Have I presented this part?
Yeah, yes, you have.
Thank you. So the indication for open surgery has been narrowed now to very few occasions where you have anatomic abnormalities, such as the ureteric junction obstruction or proximal ureteric stricture. Sometimes when patients have a tumor that is resectable and there is stone, you may remove the stone at the same sitting with the partial nephrectomy. And sometimes when there is failure or complication of the minimally invasive like PCNL, laparoscopic or robotic surgery, we may need to come back to open. As such, usually, even if you are offering minimally invasive surgeries, you still take consent and of open in case there is need to do that. When there is some contraindication, like morbidly obese patient or scoliosis, that prevent you from doing minimally invasive surgeries, one can also open. The problem with morbidly obese patients, sometimes even if the stone can be amenable with shock well lithotripsy, to focus the stone can be an issue. And even for PCNL, sometimes you find out that to get the stone focused and puncture the calyces can be an issue. Sometimes large and complex stones can be removed by open surgeries, especially if there is a need for multiple PCNL or multiple function for PCNL. There are some controversial like financial constraints. Sometimes in pediatric populations, other options can be difficult. And then in Staghorn calculi in a non-functioning kidney, sometimes you contemplate nephrectomy. So how do we work up this patient? We need to have imaging and clearly localize the stone. And then if there is PUG obstruction, we need to have the split renal function. And then if the initial radiologic features suggest radiologically non-functioning kidney, we still need to do split renal function. We need to do other blood tests, CBC, electrolyte urea creatinine, and then urine test, cross-match blood, and take consent. Pre-incision anesthesia, usually is general anesthesia, and we give prophylactic antibiotic, first urethral catheter, and position the patient, then clean and drape. This is the common position used, the lateral position with the kidney break on the bed, and then the upper lower limb is straight, while the lower or the other one is flexed at both hip and the knee. Many surgeons go through the flank incision, which can be subcostal, transcostal, and intercostal. What informs sometimes the option is the location of the stone in respect to the tip of the 12 rib. The stone is above the 12 ribs, usually go intercostal, and at the tip of the 12 ribs, you go transcostal and subcostal, usually for the stone that is below the tip of the 12 ribs. Sometimes upper quadrant abdominal incision are done for children. Transabdominal and posterior lumbotomy now hardly you see surgeons doing it. This is where you position and place incision in the left lateral, for this patient, right lateral side. The incision is different down to the kidney. It's a muscle cutting through the external oblique, and especially if you pass through the intercostal, you may cut through the intercostal muscle above the 12 ribs, and then sometimes in subcostal, you cut through most of the muscles, including serratus, external oblique, internal oblique. So this is how you deepen down the incision down to the ribs, and then open the periosteum of the ribs, and then scrape it off. Sometimes you break the ribs, as in this case, the rib has been broken. Then first thing is to open the gyracia fascia and then look for the lower fall of the kidney, and just medial to it, you may pick the ureter. So once the ureter is picked, it's followed off to the non-dissect. Usually we don't dissect it completely. Follow it off to the renal pelvis, and then the parts around the renal pelvis, sometimes there may be some adhesions, should be dissected. And then the renal pelvic exposed. And then simple pallotomy can be done and stone retrieved. The pallotomy can be done between the stay sutures, but sometimes you may even feel the stone, and at that instant, it's better to just cut over the stone and retrieve it. Use of Langenbach can help sometimes to put it into the sinus and retract that, expose the pelvis better. Occasionally, there may be need to extend the pallotomy radially towards the renal tissue. And then if you are to make, if the stone is big, you can make a U-shaped incision on the renal pelvis to better extract the stone. Many mechanisms have been done to remove some fragments that may be hanging behind, because even in open surgery, the clearance sometimes cannot be 100% the stone clearance as such. Some food coagulum, some irrigate with normal saline, and some even to use a cryoprecipitate, which is a concentrated fibrinogen. Occasionally, there may be need to use an anotropic nephrolithotomy, in which you cut through the renal tissue through the Brody line, which is a half centimeter from the convex part of the kidney, dipping it down to the calyx and open the calyx to retrieve the stone. In these instances, you need to close the collecting system first before the renal tissue. So you close the calyces and then close the renal tissue. There may be, this one of the patients we manage in my center has a staghorn stone. As you can see, this stone is so big that if you are to remove it via PCNL, you may need many puncture or stage procedure. But we are able to do open surgery and remove the stone because the patient cannot afford to go to have PCNL in any of the centers that is available. I usually use this re-entry nephrostomy tube, which I pass through, and the teeth, as you can see, can pass into the proximal ureter, while the male cord head here can be in the renal pelvis, and then close the renal pelvis over it. Then if there is need for second surgeries like phalloplasty and partial nephrectomy can be done immediately. Drain can be passed, it's must, while stenting is optional. The wound is usually closed in layer. These are some of the postoperative complication management. Patients should be on analgesia because this is close to diaphragm, and sometimes if there is pain, the patient may not breathe well. Intravenous IV fluid should be given antibiotics, and then catheter usually removed on the third day, and then nephrostomy usually in the fifth day. And these patients are followed up because there are some complications that can arise even after long after the surgery. So these are the complications. Immediate complications are mainly hemorrhage because kidney is well vascularized, take more than 20% of the cardiac output. As such, primary hemorrhage is very common and troublesome. Early complications include surgical site infection, and then some of the late complications include urinary fistula, recurrent stone. So as I said earlier, open surgery should be the last option. Although open surgical intervention in managing renal stone had declined significantly over the last 3 decades, it still represents a salvage procedure in a reasonable number of patients. Open stone surgery should be considered a valid alternative to endourologic management technique, a resource-poor region lacking endoscopic facility. Thank you.
Thank you very much, Doctor. You can stop sharing your screen, sir.
Yes,
Dr. Magnus seems to be back with us. Dr. Magnus, share your screen.
Yes, sir. I'm here, sir.
We haven't seen your screen yet.
Okay, I'm not sharing it.
Can you put it in slideshow view, sir?
Yes, sir.
Thank you.
Yes, sir. Good evening, everyone. Hope my voice is loud enough.
Yes,
Good evening,
sir.
everyone. So this evening, I'll be presenting extracorporeal shockwave lithotripsy. I'm Dr. Effie Magnus, Chief Specialist Hospital and Urology Center, Abuja. This is just a picture showing the shockwave lithotripsy machine we have at Chiva. I'm going to go through the following outline: introduction, brief history, working principle, indications, contraindications, then we'll look at the patient preparation, consideration, complications, then we'll go to conclusion. Extracorporeal shockwave lithotripsy is the fragmentation of calculi by means of pulse acoustic waves at high intensity. Usually at high intensity and low frequency, the waves are directed at the stone from an external power source called the lithotriptor. Shockwave lithotripsy is the only non-invasive surgical technique to remove urinary tract stones, and is the most common treatment for solitary, uncomplicated, small upper urinary tract calculi. However, there are certain stones that are resistant to shock waves. This includes the calcium oxalate monohydrate, the cysteine stones, calcium phosphate stones. It's important to say that clinically relevant residual fragments are very common following shockwave lithotripsy, and treatment may be necessary. A brief history. It started in 1980s in the medical practice. The first was the Donia HM3, which was an electrohydraulic device. This is the first generator, there's the first generation Donia HM3, which was invented in Germany. Then subsequently in the 1990s, most lithotriptors moved away from the spark gap technology into a highly reproducible electromagnetic shock wave sources. We also have the piezoelectric lithotriptors that employ multiple piezoceramic elements to generate shock waves, which were also developed subsequently. This is a picture showing the third generation CMS lithoscope. Let's look at the working principle. All clinical lithotriptors are constructed using 4 primary components, which are the shockwave generator. Then we have a focusing device, the coupling medium, and the stone localization system. Originally, the first generation used a coupling device that ensures effective transmission of the lithotriptor generator shockwave without significant loss of energy at the patient surface. In contrast, for operation convenience, all the contemporary ones we have now, including the one we have at Chiba, uses dry coupling modalities with a water cushion system. 3 primary shockwave lithotriptors have been developed over time. These are the electrohydraulic, the electromagnetic, and the piezoelectric, with a variety of focusing systems. However, for stone localization in modern lithotriptors, the C-arm fluoroscopy is the most commonly used localization system with an optional inline or offline ultrasound imaging. The combination of shockwave generator and the focusing device determines the main characteristics of the lithotriptor field. In terms of the working principle, the procedure usually starts with a low energy level, about 13 to 14 kilovolts in each pulse, which is then gradually increased. Successive shock waves result in direct shearing forces, as well as in the formation of cavitation bubbles around the stone, which when ruptured generates energy that enhances the fragmentation of the calculus. Usually frequencies of about 60 to 90 shocks per minute have been chosen currently. There are many frequencies, but these are the most common ones used currently, with a gradual increase in energy, with the aim of increasing the fragmentation of the stone and reducing the morbidity of the procedure. Generally, about 3,000 pulses are applied with a total procedure time of about 1 hour. General anesthesia is better to limit movement during the procedure, as movement can actually affect this procedure. However, commonly we do this under local anesthesia, or even sometimes sedation may be enough, or even nothing may be used. In terms of patient preparation, a clinical history, physical examination, including some investigations such as urinalysis, the routine blood workup, coagulation profile are very important. But more importantly is the CT-IBU, which is used to characterize the stone and to estimate the stone density. Many times, stones that are very hard, such as stones with density more than 1,000 HU, may not be amenable to shockwave. In terms of indications, usually for calculi that are 2 cm and below in the kidney, upper, mid, and distal ureters, these are amenable to shockwave. However, the success rate is better in kidney and upper ureter. It's actually an attractive option for patients as it provides a truly minimal invasive approach to achieve overall stone-free rates of approaching 5%. In terms of contraindications, certain patients may not benefit, especially pregnant women, those who have coagulopathy, patients who are on platelet aggregator, inhibitor, aortic aneurysms, those who have untreated urinary tract infections. Then there are certain considerations that are very necessary when you want to subject the patient to extracorporeal shockwave lithotripsy. These are the stone factors, such as the location, the burden. Many times, single stones are better than multiple stones for shockwaves. Also, stone characteristics, such as the composition we've already talked about. 16 stones, calcium oxalate monohydrate are very resistant. Also, the stone density is very important. Then in terms of the patient factors, you look at the renal anatomy. If the stone is in calycia diverticulum with an infundibulopelvic angle greater than 90, or the infundibular width of greater than 5 mm and infundibular length of greater than 3 cm, then this may not do well with shockwave. We may need to do PCNL or flexible retrograde intrarenal surgery. Also, patients who have horseshoe kidney, transplanted kidney, these ones may not benefit much from shockwaves. Then also obesity with a skin to stone distance length of more than or between 9 to 11 mm. Many times, most people say that the skin to stone distance of at least less than 9 mm is better. Then in terms of complications, certain skin changes may be noticed: bruises, petechiae, hematuria, urinary tract infection, hypertension, especially later, maybe about 5 to 10 years afterwards. Then perirenal hematoma, then the common term known as the Steinstrasse, which is known as the streets of stones, where stones can line up in the distal ureter and fail to pass out, causing colics and pain. In conclusion, Extracorporeal shockwave lithotripsy shows good results in the treatment of kidney stones up to 2.0 cm, and is an alternative to ureteroscopy in the management of ureteric calculi. Patient selection as well as appropriate techniques is key for a satisfactory stone-free rate. Thank you.
Thank you very much, sir. Thank you for keeping to time. Please, can we send our questions to the chat so that we'll be able to take your questions? We're now going to take Dr. Celsus Kalina Ondie, who is the MD of Kalina Hospital Group. He will be talking to us on pectus nephrolithotripsy. Dr. Ondie, you have the floor. Please share your screen. We can't hear you, sir.
Unmute yourself.
Your guardian angel is there. Unmute.
You see the link I've sent, just click it to,
Yes.
okay.
Yeah, can you hear me now?
Yes,
Yes, sir.
I couldn't
Can you share your
unmute.
screen?
The host didn't allow me to unmute.
I did.
Share your screen.
Okay, so I'm talking about PCNR. Can you see my slides?
Yes, put
Yes,
it on
sir. Put it
slideshow.
in slideshow. Thank you.
Okay. A PCNR was not possible before 1976 when a team of urologists, Fenstrom and Johnson, introduced a technique for creating a percutaneous access to the kidney. That was in 1976. And some people here were already practicing urology, but that wasn't possible at all because before that time, people did not know how to get access to the kidney without injuring the colon. Because then ultrasound and CT were not commonly available, were not even available. And it wasn't possible to know which patient had colon behind the kidney. And the fear was that going into the kidney percutaneously would definitely injure the colon. PCN approach, percutaneous approach is superior to open surgery in terms of morbidity, convalescence, cost in some centers, and stone clearance. Because when the stones break up into particles, sometimes the particles are not the same, and they may be mixed during open surgery. The standard prone approach to PCNR was the first approach based on technology of the day. Instrument manipulation and stone-free rest appear to be best compared to supine and lateral approaches. Supine PCNR was described by Valdivia in 1987, and the scissor time and operation time are less, and patient ventilation is best. There is also a lateral PCNR, which was performed first in 1994. It appears to be the best approach for patients that are morbidly obese, because the table is flexed, and in that flexed position, just like when open surgery is done, it appears that the kidney is much closer to the skin than when the patients are in the prone or supine position. In lateral PCL, there is significant difference in hospital stay of complication rate between supine and prone PCL. Supine PCL appears to be the most favorable of late, especially because of the advent of technology. Ultrasound scan and CT scan can help us know if a patient, one of the 10% of patients that may have, one of the few patients that may have erythrocolic, erythrorenal colon, where approach may be fraught with complications due to the possibility of colonic injury. Bilateral simultaneous endoscopic surgery sometimes also favorable when it comes to supine PCNR because of the position and because of access to both the kidney and the bladder, ureter at the same time. Globally, open surgery for stone is no longer necessary. There are some facts we need to consider. 30% of patients with stents in place have a biofilm on the stents, despite the fact that the urine culture is sterile. In some countries, people don't give antibiotics routinely anymore for PCNR. But this fact has to be borne in mind. Because if there's infection that is not taken care of before surgery, patients could develop complications like septicemia because of open access to tissue during the puncture to the kidney. The stones also harbor bacteria, and lithotripsy could cause urosepsis and septicemia. This has to be borne in mind, especially when it comes to prophylaxis, antibiotic prophylaxis. Even for patients who do not have bacteria preoperatively, stone cultures produce bacterial growth in 77% of cases as reported in the literature. Stone and renal pelvic urine sampling are more sensitive tests than bladder urine for infection, for detection of infection. So when patients do not have infection or urine tests, we should not assume that the urine is sterile and go ahead without adequate antibiotic coverage. For PCNO to be done, the lower tract endoscopy and upper tract imaging are mandatory. If you are not able to do lower tract endoscopy, but you could puncture the kidney, it is not going to be enough for you to do PCNO. And if you cannot image the kidney with ultrasound scan for puncture or C-arm for puncture, and also if you cannot image the kidney for tract dilatation with C-arm, PCNO is not advisable because you are likely to get stuck on the way. I was asked to approach it practically, so I'm going to approach it practically. Indications for PCNO are stones that are more than 2 cm in diameter. Recently, people have started talking about the stone volume, not just the size and diameter. This is a general guide for selecting patients that could benefit from flexible ureteral rhinoscopy or PCNO as an option, as a better option. Smaller stones in the inferior pole are prone to injury, damage to the skull, and it's better to do PCNO for these patients. Stones in the renal pelvis with massive hydronephrosis. Sometimes when you try to break this, this from practical experience, when you try to break these stones, they tend to migrate into the kidney. If the hydronephrosis is massive, it's so difficult to trace the pieces. And you'll be surprised to find that the patient still has stones in the kidney when he comes back for post-operative review. It may be better to just puncture the kidney and take out the stone, rather than try other approaches where hydronephrosis will not allow the stone to come out, and the stones will migrate into parts of the kidney that you may not be able to trace easily. Cystic stones are soft, and sometimes breaking and sucking the stone at the same time may be easier than other methods of treating the same stone. Stones in anatomically abnormal kidneys. In the renal anatomy may be better or easier amenable to PCNO. There are 4 types of PCNO. It's up to 24 to 30 French, and the standard nephroscope is 26 French. And the equipment is reusable. You need ample sheet to be able to maintain the tract while extracting the stones. The mini PCNO, which is also available in many centers in this country, uses trust and instruments that are 14 to 20 F. For the standard PCNO, there is a nephroscope by Wolf, it's called a Dresden nephroscope, which is only 22 French. And it's thought to be more useful when you want to minimize injury to the kidney. It's good to have all this equipment when you want to do PCNO. The ultra mini PCNO is 14 to 20 French. All these 3 equipment or 3 approaches or 3 options have equipment instruments that are reusable. The micro PCNO uses a C-or needle. With this needle, you can puncture the kidney, and it has a visualizing device in a camera where you can actually puncture straight into the stone and break the stone with laser only, because the tract is small, and you may not be able to extract the stones. You break the stones into pieces and allow them to pass on their own. Mainly for stones in the lower pole, where you don't, even though they are small, where you do not want to use a flexible scope because you can damage your scope. The instruments are disposable, so that you use once and discard, not like the standard mini and ultra mini, where the instruments are reusable. The positioning is either prone or prone is the more popular, but a lot of people are moving to supine now. And then, of course, the lateral for those that have very huge stones. Preoperative preparations are like for any standard urological kidney surgery procedure. We need a detailed history to be sure the patient doesn't have coagulopathy. Like those who are on anticoagulants, they need to discontinue anticoagulation because you are going to go percutaneously. There's a detailed laboratory workup like for all major surgeries. To me, the most important test is a urine culture and of course imaging. A CT scan may be preferable to IVU, ultrasound scan, or KEB alone for you to assess the relationship of the other structures to the kidney. Of course, only 1%, less than 1% of the population have a colon behind the kidney, where without a preoperative localization of the colon, there will be a chance of injury when you are puncturing. And also, patients that have a history of a previous surgery or physical disability, the kidney may not be located in the typical position. And so you need a detailed preoperative imaging to identify the anatomy. This will help you so much in deciding before surgery which cases you are going to use to assess the kidney. Preoperative typing and screening of blood is important, but it is not necessary to cross-match blood. As a matter of fact, I don't cross-match blood either before surgery. Because many of the patients that will need blood can actually wait until after surgery. And if a patient's hemoglobin level is normal, adequate before surgery, you may not need to transfuse at all. More than half of the patients require transfusion. IVU may be necessary, or retrograde pyelography may be necessary for patients with duplex ureters, because if you do not identify the duplex ureter and you pass your urinary catheter into one of the renal systems, and you may you may stun the patient only to discover that you cannot access one of the meatus, one of the renal meatus that has a stone, because you cannot inject contrast. So it's important to be sure that the patient does not have duplex ureters. If he has, it may be very important to pass urinary catheters into both ureters, because after injecting one renal unit, into injecting one part of the duplex systems, you may need to inject the other one as well to be able to puncture. Dr. Babagana has spoken about radionuclide scanning in case you need to take out the kidney, because the kidney is non-functional because of the huge stone. It may be necessary to take out the kidney at once instead of just doing PCM and leaving behind a non-functional diseased kidney that will cause problems for the patient like hypertension. It may be necessary to consider preoperative placement of the nephrostomy tube in place before surgery for patients that are morbidly obese. And some of these procedures may require assistance of the radiologist. There are intraoperative considerations. One of them is, are we going to use general anesthesia, epidural, or local? All these methods have been tried before, but general anesthesia is the most favorable because patient can be placed in any position without so much discomfort. It also has advantage in case multiple cases need to be explored for comfort of the patient. Epidural anesthesia is not suitable where you have to use a supracostal approach to the kidney. We need to take care of pressure positions, especially where the patient is going to be in a lateral position. People have developed complications from myonecrosis and so on as a result of positioning alone. Pressure sores, pressure ulcers, pressure points have been prone to injury. And these have been even nerve injury. They have all been reported in the past. We have to consider that you may need to do a ureterocystoscopy and retrograde pyelography in these patients. So you need to consider equipment that you are going to use for the surgery. Antibiotic prophylaxis. One study reported that 1 week of prophylaxis with antibiotic prophylaxis with a simple medication like ciprofloxacin before the procedure reduced postoperative sepsis significantly, according to their study. Recently, extra-long equipment, extra-long reflux have been developed for patients that are morbidly obese. It's important to have ample sheets available and to maintain ample sheets, even extra-long ample sheets for patients that are morbidly obese. Transparent ample sheet can help in identification of injury to the pleura or to other structures like the colon much more easily than when you use opaque, when you use ample sheets that are not transparent. It may be necessary to open up the skin to the subcutaneous tissue before puncturing for patients that are morbidly obese. Otherwise, the ample sheet can be swallowed up completely into the subcutaneous tissue and may be difficult for you to locate sometimes, and you may lose your track. Also, it may be necessary to suture the ample sheet to the skin in such a way that even if it moves into the tissue and it becomes difficult for you to find it, you can be able to maintain your track and pull it out after the procedure has been done. Access is through either the most popular access is through the superior calyx. It's through the superior calyx because this will give you access to most of the calyxes as well as the renal pelvis. The most popular access is supracostal before the middle calyx and inferior calyx. Some people are even able to puncture the anterior calyx without worrying about the colon, especially where the patient is in the lateral position or the supine position. Energy devices to consider. Ultrasonic energy is the most popular for PCNR because it can break the stone and suck the stone particles at the same time. The pneumatic is also a very popular energy device. That is a pneumatic lithotripter. It's also a very popular energy device because the stones are very huge. Laser breaks stones into so many particles, and sometimes retrieving them may be very difficult unless one is dealing with a very small stone. Of course, energy devices should be combined depending on the density of the stone and depending on what one finds on the table. Sometimes the particles migrate into difficult calyxes and it becomes necessary to use a flexible nephroscope. And in that case, you cannot use ultrasonic or pneumatic energy devices so easily. It may become necessary to switch over to laser. The complications one will find, of course, after breaking the stone, we need also to consider extraction device. Stone forceps, stone extraction devices, domial baskets of different sizes are all going to be very useful. It's good for one to have all options available because sometimes one option may not be adequate. You may need to switch from one equipment item to another. Complications you may find, the most common I have seen is hydrothorax or pneumothorax. I've had 2 patients so far with pleural injury. It's very important to consider this when you are doing supracostal puncture. You need to check carefully and be sure there is no injury, because if there is, in one case, there was injury, it wasn't recognized in the theater, and there was no problem until we removed the nephrostomy tube. And then the patient started sucking in fluid because of the negative intrathoracic pressure, started sucking a lot of urine into the chest. And at 2 a.m., I got a call from the nurses that the patient's SpO2 is low and the patient is having respiratory difficulty. And I didn't call for ultrasound scan or chest X-ray. I knew that there was a pleural injury. On my way to theater, I passed through the house of the perioperating nurse, and we came together. And I told them to get the patient to theater before I come. The patient was on the table when I got to the hospital. And we just put a chest tube, and that was the end of the problem. The second patient, I recognized the injury on the operating table. With experience, one can go ahead with the surgery. once ampler sheet is in place, one can go ahead with the surgery. And when you finish, put a chest tube before coming out of the theater. So bowel injury, I've not experienced anyone, but if a patient has fever, patient has bowel abdominal distension after surgery, you don't need to start wondering what could be going on. The best thing is to assume that it's bowel injury. Give a patient enema and give a patient 2 colors suppository. If you can avoid commencing oral fix immediately, it will help. And they change the antibiotic regimen. Most of these injuries are extraperitoneal. If you do a KEB X-ray or ultrasound, sometimes you may find gas, but then that cannot help you because you puncture the kidney and you went through the scan. And it may not be very easy for you to make a diagnosis if the injury is very small. All you need to do is delay feeding the patient and change antibiotics, add metronidazole, something to take care of gram-negative bacteria into the regimen. I had 2 patients that have ileus and abdominal distension, mild, not so severe after surgery. I delayed removing the frostomy tube for 1 extra day, and then I put them on adequate antibiotics, delay oral feed for 2 extra days, and they were fine. But in some cases where there is evidence that viral contents are passing through the nephrostomy tube, or where there is evidence of significant injury, the advice is to withdraw the nephrostomy tube until you can see viral contents passing through the tube and leave it there for some days, and then delay oral feed, and eventually, when the drainage reduces or stops, we can remove the tube. When the drainage stops without any problem, you can do contrast studies for the colon and see if there is persistence of significant tear in the colon, in which case you may leave the nephrostomy tube. After withdrawing it from the kidney, you may leave it for some time until the drainage stops. Because the injuries are retroperitoneal, they are not likely to cause any significant problem. Acute anemia means that there was significant vascular injury, where the patient's hemoglobin drop is very significant. And if the patient continues to bleed for some days after the surgery, it may become necessary to carry out contrast studies to see if there are any AV fistulas. A vascular surgeon may be required to embolize the fistula. I've never had any problem with this so far, and I've been lucky so far. Extravasation of fluid into the retroperitoneal space should not be a problem. A lot of this fluid will get absorbed, especially where it becomes necessary to withdraw the nephrostomy tube until the drainage stops. You can climb the nephrostomy tube and see that there is urine going down the stent into the bladder. The urine is blood stent. There's no obstruction. There's a stent in place. Then the fluid will get absorbed and it will not be a problem. Intraperitoneal extravasation is most serious, but most of the punctures do not involve the peritoneum at all. I've never had any instance of intraperitoneal extravasation, but it is reported in the literature, and it may require passing, it may require doing a paracentesis or passing a tube into the peritoneal space to drain the fluid, and may require delaying removing the nephrostomy tube. It's very important to put a stent. Most of the patients have standard PCNR because the stent will help to reduce the extravasation, and it will also help the patients to dry out faster. In one case, I didn't put a stent because I felt I did a good job, and I removed the nephrostomy tube. I think the patient came back, called me back for home. They were leaking urine from the puncture side. Obviously, there was a small stone that had moved into the ureter, which I never recognized. So I called him back to the hospital and put a stent, and the leakage stopped. So for those who are just starting these procedures, it's very important to put a stent in all your patients. Except where you do micro or mini or ultra mini. Sometimes you don't need to put a stent. And where you are able to, under fluoroscopy, establish that you clear the stones 100%, and right in the table, you are convinced that the patient is draining freely, draining urine freely, that is blood stent. Sometimes you leave in the nephrostomy tube. Sorry, you leave a urinary catheter for 1 or 2 days, and you're sure that there's no drainage from the puncture side, then you can remove the urinary catheter before the patient goes home. A colonic injury is the most dreadful of all of them, followed by AV fistulas. The technical considerations for most of us will be to think about whether you are going to need to use a flexible scope into the kidney, where you have a difficult position for the stone, or hydronephrosis is very minimal, and you are thinking that you may need to localize the stone, and you are worried about multiple punctures or bleeding, and you want to be sure that you are puncturing directly on the stone, then you may need a flexible scope on the stone, so that when you puncture, the stone can tell you that you are puncturing in the right position. In that case, you may need a supine position for PCNL. You also have to consider whether you are going to do bilateral PCNL and counsel the patient appropriately, where you can finish the procedure in a very short time, very minimal blood loss. This hydronephrosis will allow you adequate puncture, easy puncture. Bilateral PCNL is also a standard procedure, and you may need to prepare for both sides. You also need to consider if you are going to do multiple punctures. For patients with a bifid renal pelvis, sometimes it's so difficult for one puncture to allow you to do anything. For patients that do not have hydronephrosis, sometimes one puncture will be difficult. For patients that have huge stone burden or multiple stones and in multiple cases, it may be difficult for you to be able to assess the stones with only one puncture. I've spoken about the need for DJ stenting. So this is a technical consideration that will help you minimize the length of time of putting in the nephrostomy tube before you remove it. You need to look at the color of the urine. If you do PCNL and urine is completely clear, that is very worrisome. That is the bladder urine, because you're going to put a catheter. If you finish PCNL and the bladder urine is completely clear, that will be very worrisome, because there may be stone that will move into the ureter that's completely obstructing the ureter. In that case, it's very important to put a stent to be sure that you don't discharge the patient and the patient comes back draining urine for the nephrostomy puncture site. Oxygen saturation is also a technical consideration. If you turn the patient prone and SpO2 goes down, then you're not going to do well with that patient. You may need to turn the patient back in a supine position. Just 2 months ago, I did one PCNL and the patient had a pus inside the kidney. The patient did not grow any bacteria, and we thought that it was tuberculosis. We did GNS part, we did all sorts of tests. We couldn't confirm tuberculosis. Then we went ahead and put her on a tuberculosis regimen prophylactically for 3 months, and she came back. And we went back to the kidney, and there was a pus in the kidney. And then when we turned up prone, and punctured the kidney, we see found pus in the kidney. And the patient desaturated immediately. And we had to turn out supine. And then she was resuscitated by anesthetic successfully. And we went ahead to evacuate all the pus from the kidney. And we had to send her to ICU in a national hospital. So if the patient is desaturating, you cannot continue with the procedure. You need to change the position of the patient. And you need to see if you are compressing the inferior vena cava significantly. And these are all patients that are going to be prone to DVT and so on. So saturation is very important. You may need to change the position. You also need to consider tamponade of the kidney. If you finish PCNL, you have done a good job. The patient is bleeding so much. Instead of putting in the nephrostomy tube, it may be better to use a balloon catheter, which you can inflate the balloon, and that can help, not so much, because that will put a lot of pressure on the kidney. Dilator can help to control the bleeding. And of course, antibiotic prophylaxis on the table before you start breaking the stone. Because as you're breaking the stone, we're releasing bacteria into the circulation. Because we puncture the kidney, there's contact with the blood circulation of the patient. The patient could develop septicemia. Also think about your own protection. It may be necessary for you to be well kitted. Like here, we're wearing radio protection. We're wearing glasses that will protect us, protect the eyes from radiation. We're also wearing something to protect the brain. They say shield. Also, you can wear to protect the brain from radiation, and also the gloves. The gloves. This patient, this procedure, the gloves were also radio protective. The special surgical gloves that have some radio protective quality, so that when you are puncturing behind under the C-arm, you don't expose yourself to so much radiation. And under the surgical drape, there is a lead apron or thyroid shield. It's also a thyroid shield around the thyroid gland to protect the thyroid gland. These are all technical considerations that can help to achieve a successful surgery without unduly exposing the surgeon. Then the bigger the stone, the bigger the tract you have to consider. Here, this was all the stone. It was
5 more
huge,
minutes. So
and then, okay. And then you need to use a standard access with a 26 French nephroscope, because when you have a 26 French implant sheet, you'll be able to pick out big chunks of stone from the kidney. You cannot afford to break this stone into tiny pieces because it'll be very difficult. When the stone is soft, you will need to think more of ultrasonic lithotripsy, because it will be so easy to break the stone into tiny pieces and suck out immediately. When the stone is hard, you need to consider bigger implant sheets so that you can pick up bigger chunks of stone from the kidney. Here, the patient had the bifield renal pelvis, so we have to puncture multiple times. And one puncture will not be enough, because you cannot access this stone here from the upper calyx. You cannot access the stone at all on the superior calyx. People are punctured even as much as 6 times to be able to get good stone clearance for some of the patients that they have reported. So yeah, it's a technical consideration, because if you do not puncture or make all your punctures before you start, once you're in the kidney, when you want to inject contrast, it will be very difficult for the contrast to be localized to the calyces. So it becomes very difficult to puncture once you have dilated the tract and once you have accessed the kidney. So it's good to achieve all your puncture, place the guide wires before you start dilating all the tracts, because once you do that, you can no longer puncture easily. You need a standard theater with all options available, because you may need to switch from one option to another. If you don't have equipment, like the first urinary stone I tried to do, I did everything possible for the stone not to migrate into the kidney. And the stone migrated into the kidney. And then, of course, I couldn't continue, because at that time, I wasn't really flexible. So you need to have all the options, because if you don't, the procedure may fail. And you need to have a very standard team, because if you're going to turn the patient, you need somebody to control the monitor, to control the laser, to control the C-arm. So you need multiple hands in the theater. Otherwise, it will be so difficult to do VCNL. Thank you very much.
Thank you very much. Very lengthy, but was worth the waiting. Quickly, please, like I say, please put your questions on the chat. We'll go through them, and we'll quickly ask Dr. Taiwo Alabi to take the floor. Share your screen, sir. When you have done 10 minutes, we'll give you a warning. This was very long. Taiwo, share your screen, please.
Something that.
please put it on slideshow. Put it on slideshow.
That's a minute.
You're almost there. Just get to the glass slide thing, or you go up and click slideshow.
Hello?
Yes, we are seeing your slide, but click the slideshow.
Yes.
Okay, showing to improve your internet quality, can you remove your video?
Yes, let me do that.
Remove your own, so because your internet has problem. Stop showing, see where it is written stop video, so that
Yes.
we don't see you.
I'm doing that.
That will improve your internet quality.
Internet.
His internet has problem.
Okay.
Can we
Maybe
take
we
the next
should.
presentation if he
Yeah.
can sort out
Please,
his internet?
please, you
Hello,
need
can
to
you hear
unmute.
me?
Yes, we can hear you now.
Please unmute Dr. Akinola also.
Okay.
Alabi, proceed. Can you turn to slideshow? Okay,
His
let's go to
internet
Dr.
is
Akinola. We'll come. Yeah, let's go to Dr.
Akinola.
Akinola. We'll come back to him.
Alabi, stop sharing your slide.
Do we have it now? At last. On slideshow now.
No, your internet has problem.
Take time and change the internet while we go to the next person.
All right, don't do that. Sorry about that.
Dr. Akinola, please.
Okay, Akinola. Share your slide.
1 second. Okay, is my slide visible? Am I audible?
Yes, sir.
Yes.
Okay, good evening, sir.
We're on slideshow.
Okay, excellent. Good evening to this esteemed audience. I would be presenting complications of stone treatment. The outline is as such. I'm going to start with discussions of the complications of shockwave lithotripsy, followed by open stone surgery, then PCNL and ureteroscopy. In extracorporeal shockwave lithotripsy, the complications mainly arise from the formations and the passage of the fragments, infection, and the effect of shockwave on renal and non-renal tissue. It's a known fact that residual fragments, defined as greater than 4 millimeters, increase the risk of complications such as obstruction, infection, and renal compromise in the involved moiety. Factors that determine the effectiveness of that fragmentation and stone passage include things like the composition, which the prior presenter had mentioned. It's known that struvite stones, uric acid stones, calcium oxalate dihydrate stones are softer in general than calcium phosphate stones, calcium oxalate monohydrate, and cysteine stones. The other factor that's important, which has also been mentioned, is the location of the stone. Lower pole stones in general, both in ureteroscopy and in extracorporeal shockwave lithotripsy, are known to be more difficult to clear. And in fact, as a result of that, the AUA, American Urologic Association, recommends that we do not offer as well to patients with lower pole stones greater than 10 millimeters. The stone size is also quite important. We know that as the stone size increases, the stone-free rate decreases. And in fact, complications rate also increases. For stones greater than 2 centimeters, for example, partial obstruction is seen after a single ESWL in up to 19 to 50% of those patients. And for this reason, the American Urologic Association also recommends that we don't offer ESWL treatment as first-line treatment for stones more than 2 centimeters. And for staghorns, they recommend against its use in general. Of course, there are times when with stones greater than 2 centimeters, you could combine shockwave with other modalities, but primarily it shouldn't be first line. Now, Steintracer had been mentioned earlier. If you look at the picture on the right, you can see the distal ureters with stones on both sides in this patient. This was an image I found. And basically, the larger the stone, the higher the risk of this. By the time you're dealing with stones greater than 2 centimeters, about 1 in 4 of those patients are at risk of developing Steintracer, which is quite high. The way to really treat this is to do ureteroscopy, retrograde surgery to deal with the lead fragments, and usually you're easily able to clear the rest of the stones. Now, moving on to infection, sepsis rate in PCNL is low. It's less than 3%. It's more likely, as Dr. Ondiye said, when the UTI is present pre-procedure. So your preoperative workup is quite important. It's more likely when you're dealing with infected stones and when there's poor drainage due to distal obstruction. A pre-op urinalysis and urine culture, I think, is one of the most important tests to do for any stone surgery. And you want to, it's also important, as someone also mentioned, that there could be a discordance between what you see on voided urine specimens and the actual situation on ground. But it's important, therefore, when you go in, if you notice any signs of infection, pus, or anything like that, to really strongly consider draining that kidney, placing the patient on antibiotics, and then returning once the infection is clear. The other effects of shockwave to organs, the effect of the shockwave on other organs, both the renal tissue and non-renal tissue. At the entry site of the shockwave and the exit site, which is the skin, sometimes you'll see petechia or ecchymosis, and usually this is self-limiting. Sometimes you see arrhythmias with premature ventricular contractions being the most common. To address this, we do what's called R-wave gating, where the shock waves are delivered during the depolarization phase of the ventricle. With regards to the effect on the kidney, studies have shown that even for your routine successful ESWL, there's some damage to the intrarenal veins, the small intrarenal veins. When the damage is large enough, you can develop retroperitoneal hematomas. Luckily, the incidence is less than 0.5%. The treatment usually for this is the patient on bed rest with serial hematocrits and transfuse as needed. Usually they don't need intervention, and this resolves on its own. It's also been shown that the blood flow to the kidney that undergoes ESWL and the renal function can be decreased up to 3 weeks after the procedure. And it's for this reason that it's been hypothesized and debated on whether you can have long-term effects of that, such as hypertension. There's a lot of data for and against, but the preponderance of evidence suggests that shockwave does not cause hypertension. The same argument goes for the kidney, where the theory is that you can have damage to the beta isolate cells. Again, we do not believe that ESWL causes diabetes. In summary, I think the important thing for ESWL is to recognize your contraindications. Your absolute contraindications include things like coagulopathy, pregnancy, uncontrolled infections, aneurysms, and skeletal malformations that could preclude stone targeting. Other relative contraindications include obesity. As the fat dampens the shock wave and the success rate goes down, the fragmentation is less effective. Ultimately, patient selection is key for a successful outcome with shock as well. Going to open surgery, by far the most common complication is pulmonary dysfunction in the form of atelectasis, which is found in about 5 to 10% of patients undergoing open surgery for stones. This is mostly due to the position, which is a flank position for most of these patients. There's restricted chest wall movement due to the positioning. Also, particularly with flank incisions, especially non-rib sparing incisions, they can be quite painful, such that post-operative deep breathing is minimized, and that increases the risk of atelectasis. It's important in these patients to institute incentive spirometry as soon as possible post-op, early ambulation, which improves respiratory dynamics and pain control. Luckily, pulmonary embolisms are rare, with an incidence of about 1%. As we all know, pulmonary embolisms can happen after any surgery because generally surgery is prothrombotic, containing all the features of the virtuous triad. To minimize the risk of this, TED stockings or intermittent pneumatic compressive devices are important. Early ambulation after surgery is also quite important, and prophylactic chemical anticoagulation should also be considered in patients post-op. Pneumothoraxes are also seen, especially with complex cases, such as in patients with previous renal surgery or with infection. We've had pyelonephritis, where you have the kidney stuck to the diaphragm, or where you approach the kidney via 11th rib or super 11th rib access, where the pleura is closely adhered to the ribs. The treatment for small rents in the pleura is repair, either running repair or purse string suture. It's important to have the anesthesiologist tying. For larger tears, one should leave a chest tube. With regards to the cardiovascular complications, hypotension is quite common during in patients being put in the flank position, especially when the kidney rest is being raised and the patient's being flexed, the table's being flexed. Usually it's not of much consequence. However, in patients with some underlying heart disease, blocked vessels, you could induce ischemia if the blood pressure becomes dangerously low. One could minimize this just by being aware of it and hydrating the patient properly before surgery and monitoring the blood pressure during positioning. Hypertension, conversely, hypertension and decreased renal function can result from injury to the kidney during open surgery, both from ischemic injury and from damage to the kidney and fibrosis from surgery. This is thought to be due to loss of functional renal tissue and a dysfunctional response to the renal angiotensin pathway. We can minimize this by avascular access and meticulous surgery, which I'll talk a little bit more about that in a second. Leakage of urine is also quite important and can cause complications. Pilocutaneous fistulas can result, especially when there's distal obstruction or presence of a foreign body or infection. But usually this resolves within 2 to 3 weeks. And if there's any obstruction, one should stent the patient, as Dr. India mentioned earlier. Urinomas can also occur, but thankfully this is rare. And usually it results from a drain that is removed too early. They can be quite serious if not addressed. Can form an abscess and cause sepsis. The management primarily is antibiotic coverage. If the collection is large enough, placing a percutaneous drain and stenting the ureter and considering a urethral catheter also is important to ensure that you don't have reflux in urine back into the retroperitoneum. With respect to open pilotithotomy, you can have stone migration, and you can either have the stone migrate proximally into the calyces of the kidney or distally into the ureter. The way to prevent this proximal migration is to put some pressure, potentially with a manual pressure behind the stone, cut directly on the stone, on the pelvis where the stone is, and you can occlude the ureter by using a vessel suture. Retrained fragments during open surgery are a big problem because you can't really see directly inside the kidney. And these are niduses for further stone formation. One can address this by doing intraoperative flexible nephroscopy to identify the segments that are proven difficult to find. And an ultrasound intraop can also aid in identifying where the stones are. With regards to anatomic nephrolithotomy, the main complication or the concern is significant hemorrhage. On average, the blood loss, even in expert hands, is about 778 mils. Significant hemorrhage defined as greater than 1 liter blood loss is seen in 10% of patients that undergo this procedure. As the first presenter mentioned, it's very important to identify the Brodell's avascular line. Okay, and this is found at the junction of the anterior 2/3 of the kidney and the posterior 1/3 is basically where there's a laxity, there's a scarcity of vessels from the anterior and the posterior circulation. The way to identify this exactly during surgery is to do a meticulous dissection of the renal artery, identify the posterior branch, occlude this, and give the patient methylene blue so that the anterior circulation is outlined and you can see a clear demarcation where you can then incise. It's also important to control the renal artery during surgery, but one has to keep in mind that you must minimize ischemia time to warm ischemia time to about 30 minutes. If you need this, if you anticipate needing more than this, you should cool the kidney down to reduce the risk of ischemia and damage as a result. Sorry. With regards to post-op hemorrhage in patients having this procedure, selective embolization is angioembolization is quite useful, but if the bleeding continues or the patient is unstable, one needs to open up immediately.
5 more minutes.
Moving on to PCNL. The most important part of PCNL is the access, as Dr. Undi had mentioned. Pneumothoraxes, hydrothorax are one of the most common complications, especially for upper pole access. It's found in about 10% of supracostal punctures. A chest tube is important in addressing this complication. With PCNLs, about 5.7% of the patients require blood transfusions, and only about 1% have a significant enough bleeding that they require some intervention. Intraoperatively, sometimes when the bleeding is quite much and you can't see, it's important to ensure that your access sheath is actually inside enough, because sometimes you're pulled out and then you're bleeding from your injury anterior to your access sheath. You want to advance this and then continue your procedure. If the bleeding is significant, as Dr. Ndiaye said, a balloon, nephrostomy tamponade balloon is quite important. This can be inflated along the tract and left for 45 minutes. If bleeding persists after that, you can do angioembolization. Several other injuries can occur, such as splenic injuries with left renal access, especially when there's splenomegaly. This requires angioembolization or surgery to fix. Liver injuries can also happen during right renal access. It's important one recognizes this early and stops. And most of the minor injuries can be managed conservatively. If the injury is interperitoneal, usually would require open surgery. For extraperitoneal injury or retroperitoneal injury, the colon can be injured. This happens in patients with a retrorenal colon. This can be identified on proper study of the pre-op imaging, and that's quite important. It's only seen in about 0.6% of the population, so it's rare, but it highlights the importance of that review preoperatively and planning of your surgery. If you have a colonic injury, you can withdraw the tube into the colon to act as a colostomy. You pass a stent to drain the kidney or a nephrostomy tube separately into the kidney, and you keep the patient nil per oris, TPN if possible, dilation to prevent accumulation of fluid, and then you can study the tubes after a while and remove when no longer necessary. The duodenum can also be injured, especially the second part, This is a rare injury, but can happen if you go through the renal pelvis anteriorly into the duodenum. Once this is recognized, you should place, should drain the collecting system and pull the nephrostomy tube into the renal pelvis. You consult the general surgeon, start the patient on antibiotics, keep them neoperoral, and start TPN and put an NG tube for suction. After 1 week, usually you can study with imaging, and if the fistula persists, then you may need surgery. With ureteroscopy and laser lithotripsy, with ureteroscopy and retrograde intrarenal surgery, bleeding is a common complication, but it's usually minor. It's usually due to minor mucosal injuries and superficial blood vessel ruptures, which is self-limiting. Major vascular injury can occur, such as with semi-rigid ureteroscopy, when you are working over the iliac vessels, the crossing of the iliacs, and patients who are not well paralyzed, who box or jumps during these procedures, you can puncture the ureter and cause injury to the vessels. Thermal injury in closed calyces can also occur when you use high energy. Generally, we advise not to use continuous energy of more than 25 watts in stone surgery in closed calyces. Sepsis is also one of the feared complications of ureteroscopy and laser lithotripsy. Thankfully, this is rare, and preoperative evaluation is key. Moving on to access failure. This happens in about 10% of patients, and in fact, I counsel all my patients preoperatively about this risk. There's a 10% risk. It's usually not nice to go into surgery and then come out with the patient having no idea that this can happen. This can happen when there's ureteral orifice edema. It's important to be patient in these situations. You look for ureteric jet. You can use methylene blue to help identify the ureter in that situation. If you have a narrow ureteric lumen or orifice, you could try smaller scopes, 4.5 French semi-rigid ureteroscopes or 7.5 French flexible ureteroscopes. You want to avoid excessive force. And then you can always stent these patients if you can get a wire in and come back. By the time you come back in 2 weeks, the ureter is widely dilated usually. Ureteral angulation and tortuosity can also prevent access into the kidney. And the way to overcome this is to try different sizes and types of guide wires. Flexible, you can use Nitnor guide wires, which slide very easily, but either straight or angled, smaller sizes. And oftentimes you can do what's called visual guidance, where you place the semi-rigid ureteroscope by the orifice, engage a little bit, and then maneuver your scope a little bit to try to identify the lumen until you can. If you're able to pass one wire, you could then pass a stiffer guide wire to keep the path straight and facilitate your surgery. When you have a large prostate and intravesical protrusion, which you're only finding out at surgery, usually prayer is your option because you usually can't access the ureteral orifices. And this, then raises the question, do you treat the prostate at the time to expose the UO? If you anticipated a pre-op, are you going to change your approach and go from above? So these are all things to consider. Lastly, one of the most difficult situations is having an impacted uretrovesical junction stone, because this doesn't allow any access into the ureter. You sometimes can't get a wire in, and you can't get any leverage. You can't have your scope supported by anything. So what I usually would do in these situations is try to nudge the stone in a little bit so that I can dislodge it, pass a wire beyond it, and then work. And then endoscopic injuries can happen, graded by Traxler et al. In 2013. Mucosal tears are most common, but these are usually self-limiting, requiring just stenting, and usually they heal within a few days. You can have grade 2 injuries, which are injuries to that involves the smooth muscle, and then perforations where you can see fat on the other side. Submucosal tunnels or false passages. An example of these injuries usually occurring in tight ureters where there's ureteral tortuosity or angulation. Impacted stones and edema increase this risk. Experienced endoscopists usually can continue if this isn't, if it's not an overt perforation, it's a small perforation. You can, once you identify, place 2 wires to allow vision into the place and pass a small access sheet just to bypass that part and do your work. It's important to avoid stone fragments tracking into the space, however. And you definitely don't want a stone to perforate or go outside the ureter. But interestingly, the stricture risk is actually low with this. Ureteral perforations, as I described, when they happen, and they're identified, one should stop immediately to avoid a urinoma. Proximal ureter is the most common site because it's the thinnest. Again, with impacted stones and edema, this is more common. What you want to do is just pass your stent. If you have a stone that falls out from this opening, don't chase it. The temptation is usually there because you can see it, but one should avoid chasing the stone. You pass your stent. Interestingly, the risk of stricture, even with perforation, is only about 5%. Uteral avulsion is the most feared complication in ureteroscopy. It again usually involves the proximal third of the ureter, which is the thinnest. The mechanism is usually when you're pulling a stone in your basket that is too large, and what happens is you shear up the ureter, and then the ureter can come out from the urethra. You can either have a single point avulsion where it's just that, or you pull out the entire ureter itself, as seen in this picture. Okay. If you have a single point avulsion, you usually have to convert to open surgery, and a pyloureterostomy or ureterostomy would be used to repair that. If it's a 2-point avulsion, you then have the option of an ileoureter or ultratransplantation. Lastly, you can have instrument failures during ureteroscopy and laser lithotripsy. The average number of times you can use a scope used to be about 3.25 to 14 times, but more scopes seem to have increased that durability to about 50 scopes. It's important to take good care of your instruments. Most of the damage occurs during cleaning. A lot of the damage, about 50% of the time, the damage is when the scope is being cleaned. So that's an important part of maintenance of your scopes. To preserve your scopes, you can consider disposable ureteroscopes for difficult cases, such as large lower pole stones. If possible, always relocate those stones anyway. Have backup ureteroscopes in place. And lastly, you can have basket failures. The way to avoid this is really to minimize the reuse of baskets, and then avoid grabbing really large stones. Sometimes you grab a stone and then you can't get the stone off the basket. I sometimes have dealt with this in the past by just sneaking a 200 micron fiber into the scope through the same channel that the basket is in, and breaking the fragments within the basket, and then releasing the basket. If that's not possible, of course, you can disassemble your basket, take your scope out and go next to it to break the stone and remove the basket that way. Thank you very much for the opportunity to speak with this distinguished audience.
Thank you very much, sir. Very extensive. You had to do everybody's work in order to be able to get everybody's communication. Thank you very much, sir.
Thank you.
Alabi, are you with us now? Dr. Alabi?
I can stop sharing your slide.
I don't see Dr. Alabi.
Live is here. Okay, Alabi. Unmute yourself if you can.
Am I audible?
Well,
Yes, sir.
try and see if you can share your slide now.
This is so cool.
I wonder if you'll be able to present, but let's see, you're beginning to share your slide. The internet source you're using is problematic.
You may wish to change the position of your modem.
Okay.
Oh.
Okay, put it on slideshow.
How is it now?
Put it on slideshow.
Is it on slideshow now?
No.
No.
Maybe we can continue the presentation this way so that we can move on.
Okay,
Slideshow,
go ahead. The problem is
the network.
okay. Go ahead. The problem is the network. His network is not okay. So let me see if I can share for him, if he'll be able to talk.
Yeah, that's if you can talk. Yes.
If he can talk, the problem is his internet is a problem.
He can actually talk with his phone.
Mm.
If he's not able to talk, he can talk, put on your phone, let him call your phone, and then you talk through you.
He will not be seen now. So can you see his slide
Yes,
now?
what the mean is that he will call you.
Can you see his?
Yes, I can.
But if he doesn't see the slide, he won't be able to follow.
Alabi, you can start talking. No, he has his slide on his own side too. He will tell you to change slide.
It won't work.
Can you talk to him on the phone? Let's do. Okay.
I think it will be difficult. Let us stop and take the other questions.
Okay.
Because his internet is bad. If he's just sharing slide, I can share his slide. But the problem is his internet is not seeing us, so he can't. There are some beautiful things he has prepared. But,
Beautiful things you need.
Mm.
Fueled by technology.
Yes. And that will further reduce because his internet is not working.
Okay, we'll set another time. We'll set another time. We'll set another time. All right.
Okay.
Taiwo, sorry, we're actually running out of time. We have barely 60 minutes left to go on this program. I want to thank all the presenters for excellent presentations. And just want to make a few comments before we take questions. I think for us in Nigeria to say the open surgery is last resort will not be acceptable because majority of Nigerians get open surgery. And as such, for having said that, guidelines must be local because at this point in time, we don't have most of the technology required. So we're not going to be able to take the AU or EA guideline for stones. I also want to mention that in ESWL, we don't allow patients more than 2 sessions for now because long-term effect of ESWL is a paid kidney where the patient has fibrosis in the kidney. So if a patient stone, because of the density over 1,000 Hounsfield unit may require more than 1 session, apart from the size of the stone, we advise the patient to have an alternative treatment. Dr. Ode did mention about not cross-matching blood. I mean, my opinion is that why most of the time you may not require the blood. We have a system in our country where blood is not readily available. So that might be a bit risky for the patients. My attitude, the attitude I take is it's better to have the blood and not use it than to have it and not use it. That, of course, may be considered to be wasteful also, but in the developed countries, you can get blood at a click of the fingers. That may be a bit risky for us. A lot of people who are doing PCNL will rather go through a lower pole or middle pole than go for the supracostal punctures. But like Dr. S.K. Parr has always emphasized in his lectures, supracostal punctures are not that dangerous because each time you do a supracostal puncture anyway, you must go through the pleura. It's the lung injury that is the problem with supracostal punctures. We'll just take questions and then take it from Dr. Proseke. Can you take over and just do the
Okay. Okay, there are some questions. The first question is, are there instances when you use PCNL for proximal urethrics or PUJ stone? How do you adapt the sheet nephroscope for this? I guess this is to Andy. Alabi, can you stop sharing your slides so that we can see others?
Dr. Ndi, did you hear the question?
Dr. Andy. Let me see whether it's
doesn't seem that it's available immediately.
Let me
What's
see.
the question again?
It's possible it's muted.
Okay, he's here. Andy is here. He's here. Okay, he's muted. Please unmute him.
Okay, Andy, unmute yourself. Unmute yourself, Andy.
Dr. Andy, unmute yourself.
Where is your guardian angel? Okay, it's muted now. Okay, Andy, there's a question for you. So the question says,
Okay.
Now there's a question.
It's a host. It's a host
Yes.
that was not allowing me to.
I've told you not to be muting yourself because. Okay, so let me. Okay, the question is, are there instances when you use PCNL for proximal urethric stroke, PUJ stone? That's the first question. The second question is, how do you adapt the sheet nephroscope for this?
Okay, I use PCNL for not proximal urethric stone, no, but for PUJ stone, yes. If there is massive hydronephrosis, yes, but the patient must be counseled preoperatively. You don't need the implant sheet to get to the renal pelvis. Once if there's hydronephrosis and the implant sheet is in the kidney, in the calyx, you can easily go to the renal pelvis with a nephroscope. The implant sheet doesn't have to follow the nephroscope. Completely unnecessary. But you have to have hydronephrosis. If there's no hydronephrosis and there's a stone in the renal pelvis, if you try to move the nephroscope to the renal pelvis, if it's a standard nephroscope, you are likely going to injure the kidney because it's going to cause a lot of abrasion on the mucosa. But if it's mini-peg or mini-peg is shorter than a standard nephroscope, it may not reach. And if it is the Dresden nephroscope, you probably can pass. But you need hydronephrosis. If there's a stone in the PUJ and there's no hydronephrosis, flexible ureteral endoscopy is easier than PCNL.
It's 19 hours.
Okay. For PCNL, I wanted to make a comment that my transfusion rate is less than 30%. And for patients that will need transfusion, we can get blood within 30 minutes. So for that reason, we follow what they do in the West. We don't cross-match blood because the transfusion rate is very low.
Okay. Now to Magnus. Magnus is not here again. To Magnus, Professor Azodo, you can answer the question.
Magnus is here. Magnus is here. You need to unmute him. Please stop muting yourself because you. Magnus, unmute yourself, please.
I can't find.
It's on the second row. If you are using the computer, it's under on there.
Okay. Well, it's not there. That's him. Let me use, but I told him before he shouldn't be going up and down. Okay, Magnus, I've unmuted you. I've unmuted you.
Yes, I'm here, sir. You just unmuted me, sir.
Please don't be going up and down.
Thank you, sir.
Okay, the question is
your question.
Yes, the question is ESWL truly non-invasive? Wouldn't you put a stent? Also, you did not talk about patients with ureteric obstruction from strictures or PUJ obstruction.
We will not do ESWL for those.
Thank you, sir, for the questions. Yes, ESWL is truly can be regarded as truly non-invasive because the place of ureteric stenting is not routine. There are arguments for and against ureteric stenting in extracorporeal shockwave lithotripsy. Some have argued that the place of stenting, well, may prevent colics, like in the case of the Stens-Strauss, which is one of the complications we know about shockwave. But that is usually not a common thing, especially knowing the fact that in ESWL, many a time you do it for stones that are less than 2 cm. Stens-Strauss, which causes ureteric colic, are usually for larger calculi, when you have a lot of stone fragments or particles. And in addition, those who have said ureteric stenting may not be necessary at the fact that it's a foreign body can increase the patient's chances of having a urinary tract infection. Also, a repeat procedure is necessary for removal of the ureteric stent. In addition to the fact that, ureteric stenting sometimes may even impede or reduce the chances of stone-free rates in patients. However, there are selected cases where ureteric stenting may be important. Just like I said, when maybe it's used for stones that are larger than 2 cm or large calculi, as well as the fact that patients who have impacted calculus, where you may suspect some form of mucosal tear in the ureter. So you may want to stent in such scenarios. But routinely, we don't, even in our practice, we don't stent routinely. Thank you.
Okay, it says.
And also to mention patients who have also you did not talk about patients with ureteric obstruction.
Yes, usually patients
or PUJ obstruction. Now, if the kidney is obstructed, it's not a kidney for ESWL. The obstruction, you must remove the obstruction before you can talk of ESWL. So if a patient must have ESWL and he has a PUJ obstruction, you have to put a stent first. And if you can't, then that is not a candidate. If you have a patient with ureteric stricture, it's also not a patient for ESWL. You should do a PCNL instead. Thank you.
Thank you, sir.
Okay, the second question to you again is, it looks like ESWL is no longer popular among urologists. What do you say?
Well, ESWL may seem not to be popular because one, the cost for acquiring the equipment is a factor to be considered if you must engage in ESWL. In addition to the fact that many a time, just like we said, is usually effective for properly selected patients, not just all stones. Stones that are softer, there are some stones that are resistant to ESWL. In addition to the fact that, retreatment may be necessary. So commonly for those who have ESWL, they may use it, as adjunct to some other modalities, maybe either following ureteroscopy, and maybe there's some residual fragments. You don't want to go back into theater. You may have to do ESWL or following any of the modalities. So that may make it seem not to be very common amongst urologists, but I think the cost of the equipment may also be a very limiting factor in this case, because I'm aware that many centers don't have this.
But I do agree that ESWL is a dying art in the face of availability of laser and stuff like that. But when people don't have them, ESWL is still the best option for a lot of people. Thank you.
Do you routinely stent the ureter before ESWL?
I think he has already answered that.
Okay.
Yes, sir.
We don't routinely stent, sir, except for selected cases, impacted calculi, ureteric injuries, or you have a stricture, you want to bypass it before you do ESWL, because you need an effective drainage following ESWL for you to do an ESWL, because we depend on, or rather, the normal stone passage is the factor here. When you do ESWL, you need the stones to pass. And usually stone passage can be as long as 3 months before all the particles will completely pass out. So in that case, stenting may not be routine.
Okay, Abubakar, what is the real reason?
Sir, I didn't get the question.
Yes, what is the real reason why non-operative urolithotomy is much more expensive than operative surgery? Are patients paying for the comfort?
No, actually, I think this statement was made by Dr. Ondi, and I guess where they have the equipment, considering consumables, probably one may say that the open may be more expensive than PCNL. But in terms of acquiring the equipment to start with, I think you need to invest more for PCNL than open surgery. But probably the consumable you will need at a particular surgery, probably. But otherwise, I think PCNL seem to be more expensive than open surgery.
Okay. But Andy, you have already answered the question of transfusion rate. And also,
yes. For me, it depends on where you practice really. If you practice in a general hospital or in the teaching hospital, open surgery is cheaper than PCNL. If you practice in a private hospital, I mean, if you pay me double what you pay for PCNL for me to do open surgery, I would still prefer to do PCNL because it will take me less time, and I will not have the trouble of managing scars and managing all your problems to come with and so on. I would still prefer open surgery. I mean, I would still prefer PCNL, even if you pay me double.
If you pay me double, I will take it.
Okay.
There's some patients that come asking for open surgery. There's some patients that come asking for open surgery. I refer them to National Hospital. I don't agree to take them.
It's too troublesome.
Okay.
It's too troublesome.
Can we have CME certificates for these lectures?
Yes, sir,
yes,
we can have.
Yes, the secretary, so far as you wrote your name, we will get the participants in Excel. We usually do that. I will send it to the secretary. So it's for them to produce the, maybe if you submit your email address or somehow, because if you put your name here just as Yakubi, you may not know which Yakubi is this. So I think we need to get the email address, because when we download this in Excel, we'll see all the participants. I will usually send it to the secretary. So maybe now Esco or chairman of the CME committee, she'll take it up so that we can, all the ones we have the Excel, we can generate Excel sheets containing all the participants.
So we'll discuss with the secretary, sir. I think also you should just send me a copy of the scale also so that we can ensure that we have, because we are now a CME awarding institution.
Yes. Okay. Now, what if you attempt to notch an impacted VUGA stone first and you still can't get a guide wire past it? Dr. Akinola? Unmute yourself.
Okay, thank you for that question. So there are situations where even with gentle pushing and all that, you can't dislodge the stone. If you can see parts of the stone, you can start fragmentation. Okay, you can start fragmentation such that you create a cavity within the stone, a small cavity that you can then put your scope into. But again, all of this is at the risk of damage to your scope. All right. But once you're already inside, it's you are in a tight position and you have to make a decision. Alternatively, what you can do is you can access that same stone antegrade. You could you could do an antegrade entry into the kidney, going with maybe a 10 French access sheet and try to sneak a flexible scope down. It's tough, but yes, those situations do happen. But most times I've had this situation, I've been able to push the stone back because you can imagine that it's more dilated beyond where the narrowing is. So if you push back a little bit, it usually will give a little.
Okay. Yes,
I think also
okay.
So I think the scope size you're using also will matter, because if you are using a 9.5 French scope and you are not able to get it in, you won't make any progress. But using a smaller scope may also make it easier. Thank you.
Okay, there's another question. Okay, people are sending their email, so we'll use it to get. So everybody here can also send your email, so it will help us. There's a question. How do you manage a partially avulsed double J stent, which was neglected or stopped by concretions?
Do I take this or?
Yes, please.
Okay. Yeah, so whether it's partially avulsed or it's a forgotten stent that's been there for a long time, this a lot of times can be handled retrograde with the aid of a semi-rigid scope and flexible scope and laser. What you can do, the approaches are you can decide to break the stents at different lengths. First of all, the ureter is usually very accommodative because there's been a stent there the whole time. So you can go go into the bladder, pass a wire, okay, as a safety guide wire, and then you go into the ureter and you can start dividing the stent in sections. Or what I prefer is go as high as possible, okay, and deal with it there because it's usually the proximal curl that prevents the stent from coming down. So as much as I grab the distal part of the stent, I pull that through the urethra, and I have a clamp on that, and I can use that to gently pull while looking in at the proximal curl. Wherever I see that it's not uncurling, I can break the stent at that location. And usually you are able to get it out. Sometimes those stents are also encrusted. There's stones there, so it may be difficult, but it's usually most times you can clear it.
Okay.
Dr. do you want to contribute to that?
Yeah, before a stent can be avulsed, usually there will be a stone entrapping it. Otherwise, the stent will come out so easily. So it would not be a good idea to pull on the stent. It's better to try to trace the stent with a semi-rigid scope until you get into the kidney. If you get into the kidney and you cannot see the end of the stent, then use a flexible scope so that you can find where the stone is and break it. Otherwise, if you pull on the stent, if it doesn't come easily, if you use force, it might cause some injury or even damage the ureter. It's better to try as gently as possible until you can get your scope into the kidney, because there's always going to be a stone, even if you don't see it on the C-arm.
And if you can't get into the kidney retrogradely,
you will get into a kidney because as you are going up gradually, you find a stone. Usually, if the stent doesn't have a stone, you can pass a semi-rigid scope on the side of the stent into the kidney. Even if you have a stent in the ureter, you can still pass a scope into the kidney. So where you cannot get into a kidney is where there is a stone trapping the stent. At that point, you break the stone. So you continue to break every stone you see until you find your way into the kidney. I had a patient where I continued to break until I got into the kidney. Then the stent was transected into the kidney and floated away. So I had to change to, yes, because the stone was big, I had to change to PCNL. Eventually, I was able to get the stone out. There's always going to be a stone if the stent cannot come out.
That was the point I was waiting for you to make, because definitely if it's a very light stone, a long forgotten stone, you may have to revert to a PCNL to be able to get that out. But most of the time, like Dr. Kinlow say, you'll be able to, with the combination of first view and rigid, you'll be able to get through.
Correct. And to Dr. Ndie's point, if you can't see a stone even on the outside, usually the lumen of the stent is calcified, and that's why the stent can't uncurl. So you might have to break the stent into small pieces also, using a basket to take it out. Of course, you want to avoid breaking it into too tiny a piece, but you grab with a basket and then you break in pieces.
But the problem is actually not the stent. The problem is what is trapping the stent. If you treat the stone, the stent will come out very easily.
Sure. Sometimes it's interluminal and you can't get to it without breaking the stent, but I take your point, sir.
Yes,
Okay,
another question. How do we achieve PCNL dilation when your guide wire kinks outside the kidney?
You remove the guide wire. You remove the guide wire and start all over again. Because you cannot kink, if you cannot dilate when the guide wire is not straight, that will be disaster. You might end up perforating outside the kidney. The best way is just to start all over again until you get it right. Secondly, you need to have a guide wire introducer. If you pass one guide wire in the kidney, pass a guide wire introducer into that kidney, pass a second guide wire, have a safety wire. If you have a safety wire in place, if the guide wire you want, the working guide wire gets kinked and you cannot do anything about it, remove that wire, especially if you're using PTF wires, they kink very easily. Remove that wire and then pass the second safety wire or pass the second working wire, replace the guide wire introducer, pass the second guide wire into the kidney and start all over again. And then the bigger the guide wire, the stronger the guide wire, the less the chance that it will kink. So use 0.38 and 0.38 guide wires, not a soft guide wire for dilatation.
Somebody is saying that Abdullahi, that it would be nice to unmute all during question and answer. If that happens, we will not be able to go. So send your question.
The question should be taken on the chat.
Yes. Before we used to allow people to
we'll run out of time, sir.
Causes problem. Okay.
So we've run out of time.
Okay. From Garden City LOC. For those of you that don't know, Garden City is Port Harcourt. We have prepared for you, and let all our effort not go in vain. So please send your abstracts. We can still give you like 1 week window. And then register. If you have problem with the website, some people are saying they have problem, you can contact us directly if you have any problem at all. A lot of you have registered. You can also help us. We can assist you to book a hotel reservation. You give us your name and tell us the day you're arriving and the day you are leaving. Now, the workshop will be very wonderful. I'm sure Ondi will be there. and Taiwo that didn't present. So whatever he will have presented, you will see it live in Port Harcourt. He has prepared a very wonderful slide. Unfortunately, network didn't permit him. So all this theory that we are talking here, you will see them live in Port Harcourt if you come. We're also going to do penile implant. We're also going to do whole leg. And we have radical prostatectomy. We have so much for the workshop. So try to come and then send your abstracts. We can still extend the abstracts to another 1 week. And for those of you that participated in the national study on prostate cancer, thank you very much. I think we should stop collecting for now. We will have a small section where we will address that research during the meeting. Somebody have said that the hotel number on website for hotel reservation is wrong. Okay, I will check and correct it. But if you have any problem, just send to us directly. But we'll check that. We are not aware of that, so we'll check it and correct it. Okay, over to you, Chairman.
I want to thank, before I do, I don't know whether Mr. President, you are on today, sir. We don't want to make a comment,
Okay.
sir.
Yes, I've been very, very impressed. And I want to suggest that there are centers that are way up in urological practice. Is it possible to arrange for other surgeons, whether residents or consultants, to go to those centers, maybe for 1 week, so that they get experience? Because we cannot be complaining about lack of resources. Maybe when a new government comes and they have money, many centers will be developed. So is it possible, Dr. Andy, Dr. Fulabi, Azodo, is it possible to arrange for residents and surgeons to come to certain centers, maybe for a week, and get appraised? I've been very impressed, just that, we were brought up in the old system, and we have been overtaken by events. So, but the younger ones should be availed of the opportunity to learn these things, acquire the skills. Thank you. And then I asked, why is PCNL more expensive than open surgery? Because in open surgery, the surgeon suffers. So why shouldn't that be? Why shouldn't they pay more for it? As I said, are patients paying for the comfort of yes? Thank you.
Thank you very much, sir. To start with the last one, sir. I think somebody answered the cost of acquiring and maintaining equipment, sir, is a big issue. You can lose your telescope in one surgery.
Okay.
The cost of maintaining equipment is the greatest part of it. Okay, and so I am sure that those of us who mentioned have no problem with having people to come. The only problem that a lot of people will have is hands-on training. When a patient is paying for very expensive surgery, you'll be finding it difficult to give hands-on. But in our center, we have had residents who have come who have been spending 2 months with us, and we're able to give them a limited level of hands-on training. But I'm sure Dr. Ondi Labiani will be most willing, because we could become patient. We need to have somebody who will treat us also. And but like I said, when you're a private practice, everybody's waiting to go for a jugular. Because the patients who seem to be so friendly will become enemies once anything goes wrong. So that may be a constraint. But what a lot of us are doing is actually encouraging people to gather the patients in their location. It is your patient. Will come and work with you with your patient. we are also doing a lot of that. That will help. But we are happy to have residents, but we've also explained the limitation. But some of us are already making some arrangements so that we can actually have patients who know they are coming specifically for training. But that also has some ethical issues that has to be also be dealt with. So we're unlikely to have any other things before NAUS, but we'll continue after NAUS. Thank you very much. You have been most wonderful this 1 year. God bless you.
For me, the best approach is when a doctor refers a patient to me. All doctors that refer patients to me are allowed to meet to my theater. It's easy. It's your patient. Like Dr. Bokwe referred a patient the other time. He joined me in the surgery. Dr. Paul, I did PCN with him 3 or 4 times, and now he's doing PCN. He has got PCN once after working with me 3 or 4 times. The next month he did 1. So it's much easier if it's your patient and you follow your patient to the theater. It's very much easier like that. But for training, another thing is to get accreditation and get recognized by law. Once you have accreditation and you're recognized by law, sometimes people have to pay a fee too for the training. Like where some of us train, we actually pay a fee. So when people are paying a fee or they're seen by an institution, they pay a fee, then they are legally entitled to the training, especially where there is accreditation. With African College of Surgeons, I know there was a time Professor Bono was talking to me about applying for accreditation. I think something that we have to all consider along the way, because we all got the training and we all have to train the younger ones to replace us. And then, of course, younger urologists can also apply to join us. I interviewed the urologist to join us the other time, and we had to pay him 2 million a month. But he changed his mind after that. I said he didn't want to be interested in kidney transplant. It's against his religion. And we all know that in the teaching hospital, salaries are not even barely 1 million a month. So we agreed to pay him 2 million a month, and we agreed to give him accommodation. They changed his mind. So where the younger ones, because all of us have paid our dues, some of us had to be trained for a long time. So if the younger one wants to join and he wants to work with you, like the other guy working with Dr. Zodo, there's definitely no way he will not be trained. But when a doctor is not interested in working with you, if he comes for a week, he may not get all the cases. But if the cases are arranged or they are referred, and he comes along with the patient. I used to drive from Onitsha to Benin to join Dr. Akomabo for TURP. So if the young ones are interested in traveling and learning how to do this thing, it's not difficult at all. I never used to do the surgery, but watching the surgery can give you a lot of experience. Dr. Zodo is senior to me, started before me. I used to refer patients to Dr. Zodo. I'll go to his clinic and stand there and watch his surgery. And he will give me 50,000 naira for my friend. So this is how it's done. When Dr. Laura, when I was in National Hospital, Dr. Laura sometimes would come to my theater. I used to bring all of them and I would give them transport money, even though they are not the ones that refer the patient. It's a private patient. I never had up to 10 patients come from National Hospital to join me. I used to refer them to Dr. Zodo because I wouldn't want to refer them to myself.
Okay, sir.
So that's how some of us learned.
Okay, sir. So
I want to say something.
Okay.
Good evening, everyone.
Good evening.
Show your face.
How do I show my face now? Okay, where I look for how I show my face. Can I continue talking?
Yes.
I don't want to contribute on the issue of getting training. Yeah, as my senior colleague said earlier, one other way is actually I encourage the young ones to acquire some of this equipment personally. Like Dr. Onde said, come with your patient. Why not? I mean, you can get it hands-on. It's your patient, it's your scope. Because the issue is, these are private patients, and then using your own scope, if it's damaged, we all know what it's involved. But if a person is coming with his scope, it will actually go a long way to acquire this hands-on training. And then some centers like Dr. Zodo said, yes, pull your patients, wherever ready to go there, and then to assist, like what we are doing with Jabi Medical Center. So I think these are areas we can explore to have hands-on to colleagues who wants to build their hands on this endourology. A quick one on, hello?
Go ahead.
Yes. Impacted stone at the ureterocervical junction, really, like Dr. Akinola said, can be quite challenging because you really don't have anywhere to leverage your scope and go in. Failed, pushback. Usually what I do in such circumstances is to, look at the stenosis opening and then use my laser fiber to just cut through to expose the stone. So most of the times I actually get it successfully at the end of the day. Once I hit the stones, then I can now pass my gawa. Yes, I proceed that way. So these are some of the challenges sometimes we one encounter, but we have to find a way actually overcoming it. Thank you very much, everyone.
Okay, thank you very much, Dr. Kalba. Gentlemen, I think it's 7:22 now. Thank you very much. See you in the house. God bless you. Good night.
Thank you.
Thank you very much.